Now I'm excited to introduce today's first speaker, Dr. Rozalina McCoy. She brings a unique perspective to our discussion in that she is an associate professor of medicine at the Mayo Clinic in Rochester, Minnesota, where she's a practicing primary care physician, endocrinologist, and medical director of the Mayo Clinic Ambulance Community Paramedic Program. Dr. McCoy is also an NIH and PCORI-funded health services researcher whose work leverages real-world evidence to improve the quality and equity of diabetes care. She's particularly interested in understanding factors that lead to poor glycemic control and heighten the risk of acute and chronic diabetes complications. And she's worked both within and outside the Mayo Clinic to develop patient-centered care delivery models to improve diabetes care and health outcomes. Dr. McCoy has been an active member of the American Diabetes Association and is currently serving as the chair-elect of the Diabetes and Primary Care Interest Group. Dr. McCoy received her undergraduate degree at Harvard, her medical degree at Johns Hopkins, and completed her medical training in internal medicine and endocrinology at the Mayo Clinic, and has been on the faculty there since 2015. So we're excited to have Dr. McCoy presenting on the primary care provider perspective on time and range in the primary care clinic. So welcome, Dr. McCoy.
Thank you so much, Dr. Martin, and to all of you for joining us today to learn more about time and range. And I think how it can really help you take care of patients who are living with diabetes. So like Dr. Martin said, I am a primary care doc, and I think as we manage the complexity of diabetes and all that it entails, I do think that the ability to use continuous glucose monitors and time and range is really helpful to both make it easier for us to care for our patients, easier for our patients to engage with us. And I think ultimately it's a way to deliver more patient-centered care more effectively. So I want to start briefly by just walking you through how I think I got into this and how we use time and range in our primary care clinic. So if you can go to the next slide. So I think we'll kind of talk through three pearls and takeaways that I hope you come away with today. I think the first is really to introduce the concepts of the ambulatory glucose profile, or AGP, as well as time and range, or TIR, and show how they are really a patient-centered approach to safe and effective diabetes management during a busy clinic practice, as well as through non-visit care interactions that you may have with your patients, be it by portal, phone, or any other way that you communicate to your patients outside of visits. Because they provide very efficiently with the AGP all in one page, I think a meaningful and really actionable information about my patients' glucose values to help me make real-time decisions about their care quickly. So if we go to the next slide, I'll kind of walk you through why I think it's helpful. So when I see my patients with diabetes, and I have kind of a combination of general primary care and endocrinology practices, but when you are ready to see patients with diabetes and you need to make insulin or other medication dose adjustments, typically patients come or used to come with a glucometer. The best case scenario as they come with a glucometer is what you see on the next slide, which is their glucose log. And we have to sift through all their information, trying to make sense of patterns, see what we need to do for their medications, understand patterns. That can take time. And in the real world, our patients often do not bring their logbook. They may not even bring their glucometer. So if they bring their glucometer, we'll be sifting through, information on the glucometer, or have no information at all. And I think that really contributes to therapy, at least for me, to therapeutic inertia. We know that our patient's A1C is high, but we don't have information right there in the office to make any meaningful treatment decisions. And then time passes. Our patients may not be able to follow up with us. We may not have many resources in the clinic to follow up with our patients. So I think that lack of actionable, meaningful information at our fingertips during an appointment is a real barrier to patient care. If you go to the next slide, you'll see this is actually one of my dear patients who's a 74-year-old lady with long-standing type 2 diabetes. Her A1C at this time was 8.2%. She is treated with multiple daily insulin injection therapy. She does have an intermittent scan CGM, and I'll kind of show you how we used it to support her care. Now, she has consistent breakfasts, somewhat consistent lunches, and very inconsistent dinners that are manifest in the complexity, I think, contribute to the complexity of her management. Now, she's a unique patient in that she keeps a meticulous record of her blood sugars and her meals. And every week I get a report of this. And this is what I used to get from my patients who did keep records but did not have a CGM. So usually it's spent a lot of time trying to make sense of the blood sugars, insulin doses administered, plus the correction administered, and then on the right side, the carbs that were eaten, really trying to find patterns. And every time that she and I would do this, we'd get lost in the weeds. We would find something that was unique in any given day and find it challenging to really come up with a treatment plan and come up with a treatment plan that she would really buy into and want to make permanent insulin adjustments because every day was different. Now, when we got her connected to a continuous glucose monitor, I think everything changed. So if you go to the next slide, I'll show you her AGP. So this is the top slide of her AGP, or ambulatory glucose profile. The top, and it's all in one page and easy for us to see together with my patient. And as we look at this page, we look at this top half of the page. And she has the intermittent scan CGM, but the AGP report is now standardized, and it's meant to be the same for all CGMs to make it easier for us in practice to use them meaningfully with our patients. So the AGP shows the average blood sugars and their trends over a 14-day period. Now, it's very important to teach our patients that the data on the CGM is only as good as the data that they give it. So if they have an intermittent scan continuous glucose monitor, they need to scan their device at least every 8 hours to make sure that all the blood sugar information gets uploaded and gets saved. And that contrasts to the real-time CGM where it just gets pushed and uploaded no matter what, and you have that information. But for our patients with an intermittent scan, it's very important to make sure that they really do the scanning every 8 hours. So that's definitely right before going to bed and right upon waking up to make sure we capture those nighttime hours. So on the first half of the AGP, sorry, if you can go back, you can see a couple of things that I always point my patient's attention to, and that's this colorful bar graph. The green is the time in range, or TIR, or time that our patients spent in a safe blood sugar range. And that's what I call my patient's attention to, blood sugar 70 to 180. We need that to be greater than 70% of the time. And if you ever forget, it's shown in the gray box just to the left of it. And then we can see in different colors the time that patients spend in level 1 or level 2 hypoglycemia, and then again, level 1 and level 2 hyperglycemia, or low blood sugars, high blood sugars. And I think it's helpful for patients to see in general how much time they're spending everywhere, because the A1C, it's an average. And I know that our patients have really been taught to focus on the A1C, but it's not a helpful indicator of how they are doing, especially for patients on insulin whose blood sugars can vary a lot. Because if their blood sugars are 40 or 400, their A1C may look very nice, but that's not good glycemic control, and that's not safe blood sugar ranges. So we really need to think about what is their blood sugar doing right now. So then the second half of the AGP report that I go through with my patients is shown on the next slide. And here you actually see that glucose profile, and it shows really the 24-hour variation of what happens to their blood sugars over that 14-day period. And that makes it a lot easier for our patients and for us to see trends and make changes to their treatment regimens, because we can see what their blood sugar is on average. That's the dark blue line. Then we know that half of their blood sugars fall in the medium blue shaded region. So between 25 and 75% of their sugar ranges, right, fall in that range. And then again, building out to the light blue range. So we get to see both what their blood sugar is on average and then how much variability there is. So if there's not that much variability, it's harder for our patients and for us to say that this was a fluke reading. And it really is like that. And we can make treatment decisions. So when we look at the HEP, I always tell my patients, you need it to be flat. You don't want it to kind of vary a lot. You need to be narrow without kind of day-to-day variability, and also in range. So flat, narrow, and in range. And that really should be our goal. And then if patients have different schedules day-to-day of the week, that first page also shows you their tracing for that whole 14-day period so that you can easily see any outliers that you may want to focus in on. So for example, for my patient, looking at this, we would say, I would ask her what happened on that Tuesday when you had a low. Lows are unusual for her. She generally runs high. So we would go and see where's that red dot and focus in on that day. So I think for me on a busy day with a short appointment, we can use this one pager to really understand how she's been doing over the 14 days, where the challenge areas are, what doses we need to adjust and why, and really get buy-in from our patient because she understands exactly why we're making the decisions that we are. And it can help her also say, well, maybe I should eat differently on this meal, or I always exercise this time. I should, plan for that or measure my blood sugar. So it's really a lot of meaningful information all condensed into one. And it's a lot easier than using a glucometer. Now, if we go to the next page, which is really point number 2. So I think it's very helpful. But I think for when my clinic started doing this, the biggest question is how practical is it? Because continuous glucose monitors have really been in the realm of endocrinology and not in primary care until recently, and mostly with the intermittent scan CGM. So I think the first thing for us as we're trying to implement it is to understand the requirements for CGM initiation to make sure that our patients can obtain, afford, and then continue to use continuous glucose monitors. And that requires both having the system in our clinic to do it, and ideally also being part of a multidisciplinary team, whether it's with a diabetes educator or a pharmacist to help manage our patients together, because team-based care really is ideal in these situations. So you go to the next slide, really give you a bit of just a high-level overview of the current requirements for CGM coverage. These are the requirements for Medicare or CMS. There is variability for different health plans, but most do follow CMS criteria, though you would want to check with your patient's health plan if there's any differences. But you need to make sure that they have a diagnosis in the claims, and ideally in the note, when you see them for diabetes. They need to be treated with 3 or more administrations of insulin, which is new this year. It used to be injection. Now it's administration to make it easier for our pump patients. As well as our patients who are on NPH-based regimens. We need to make sure that the health plan knows that insulin regimen requires frequent dose adjustments on the basis of blood sugar levels. They need to see a clinician, the prescribing clinician, every 6 months. A common misconception is that it has to be an endocrinologist. It does not. It's the prescribing clinician. So we count in primary care. So they need to start to see us both within 6 months of initiation and then every 6 months of using. The testing frequency requirement for at least 3 times a day testing was removed. So it's a lot easier. That is not there anymore this year, which is fantastic. And one thing that I do, as you see in blue, is that we have in our electronic health record system, we have an ability to do kind of shorthand phrases. So this is my smart phrase to put into my note every time I see a patient with a CGM or when I'm prescribing a CGM. To basically meet all of the prior authorization criteria, because then I can just print and send my note from that day and take care of all those prior auth letters. Because basically you put in everything that they're looking for into one blurb. It's actually bolded as prior authorization specification, and just eliminates a lot of that back and forth and paperwork. And I do similar things for medications too, in case you have trouble with prior auths. So next slide. And then finally, I think for our clinic, using CGM just routine practice wouldn't be possible without a multidisciplinary team. We got started because we have really an incredible pharmacist who's part of our team. We do have certified diabetes care and education specialists support, as part of our broader healthcare system and our primary care team, but they're not located specifically in our clinic where I'm at. But we do have a pharmacist who focuses on diabetes management, and with his help, we were able to set up the LibreView account for intermittent scan CGM, connect our patients to it, and kind of keep track of their blood sugars both when they're home and in the clinic. So I think partnering with a CDCS really is critical. They can dive in deeper into the CGM report, provide technology support, helping our patients get connected and stay connected, deliver education, improve awareness of hypoglycemia for our patients who struggle with hypoglycemia unawareness, and help with insulin dose adjustments. So I want to turn it over now to Stacy, who's going to offer her perspective as a CDCES working with patients using CGM.
Thank you so much, Dr. McCoy. That was a wonderful presentation.